So let's begin in the interest of everybody's time. We have 23 participants. Jennifer, are you connected and are you able to unmute yourself? Yeah, I see you. Thank you.
Liliana, so if we are ready to start, Liliana, I think you have control of the slides. So if maybe you could move from the first slide here. Thank you all for joining us today. I think this will be a very exciting webinar combining three different areas that we would like to describe for you. This first slide just gives you a list of the speakers from the various areas within UNICEF. So from UNICEF headquarters in data and analytics, myself, Jennifer Hikejo, I serve as the coordinator for the health team in data and analytics, which includes maternal, newborn, child, adolescent health, HIV and immunization. Liliana Carvajal, who's leading our adolescent measurement work in the health section. And then from the program division in headquarters, we have Cristina de Carvalho Erickson, who is an adolescent health specialist and has been leading the work for the for PD in this area. And then we're really grateful to have our UNICEF country office counterparts joining us from Belize. So you will be hearing from Dr. Susan Kasedi and Jeffrey Nan Lee and Paulette Wade. So if anyone could please mute your microphone, that would be really helpful so that people can hear. Thank you. Liliana, could you please move the slide so I could just describe what we will be discussing today? So basically, the webinar will be in 5 parts. So we'll first just give you an overview of why adolescent mental health is such a critical area of work and that it has percolated up to the top in the 2030 agenda. Then we will move into a description of some of the measurement work that the data and analytics team is leading to capture better prevalence of mental health conditions among adolescents. Then we will turn to Cristina, who will describe for you some of the efforts that the program division is doing with a program that's called HAT, or Helping Adolescents Thrive. And then we will turn it over to our Belize colleagues, who will describe for you the field work that has been undertaken so far in Belize. And then we will end with a question and answer session. So that is how we've decided to organize this webinar, and we're really looking forward to hearing your inputs. Lastly, I just wanted to let you know that this webinar is being recorded, so it will be available to you afterwards if you have interest in going back and hearing the presentations. So with that, I'm going to hand over to my colleague Liliana, and thank you again for participating. Over.
Thank you very much, Jennifer. My name is Liliana Carvajal, and as Jennifer mentioned, I work in data and analytics, and over the past 2 years, with support of experts, I've been leading the work in the methodological work to measure adolescents' mental health at the population level. But before getting into that, I wanted to give you a brief introduction as to why this matters, why now. As many of you may know, mental health has been included for the first time in the global measurement frameworks. In the Sustainable Development Goal, in Goal 3, under Target 3.4, mental health is openly measured as part of the prevention, treatment, and promotion priorities of mental health and well-being. And the only indicator that has been identified for that at the moment is suicide mortality rate, which is just the end of like what any mental health issue could be. However, before that, before having to really get into that, we have been looking into, as part of this work, into the scoping. We have conducted a scoping review and looking into different tools and the evidence that is there in terms of the prevalence of mental health among adolescent population in low and middle income countries. And that has given us a very solid ground to start identifying the priorities of this area. One aspect that was highlighted recently by some experts were the social and cultural determinants of mental health disorders, which, as you can see in the screen, it cuts across many of the other Sustainable Development Goals. So this picture here, for example, presents a very clear framework as to how adolescent mental health has an impact on aspects like education, well-being, peace, conflict, even other aspects of development, including gender and nutrition, and is a circle because all of those aspects also have an impact on mental health. So there is a huge interconnection here that makes it even a more relevant issue to be really prioritizing in our development agenda. Cristina?
Yes, good morning, everyone. My name is Cristina de Carvalho Eriksson, and I'm adolescent health specialist from the health section in New York. And I want to continue to point out that the CRC, or the Convention of the Rights of the Child, specifically points out mental health of children and adolescents as a core part of their well-being. And they have, of course, continuous reviews of reports from countries and have made recommendations related to mental health across regions directed at countries. And these recommendations range from policy level, but focus mainly on the need to find interventions to prevent mental illness among children and adolescents, but also, of course, to provide the right services that they need. Before we continue, we just want to also acknowledge that mental health is not a static condition. And there are many dimensions of mental health, from positive mental health to severe psychosocial disability. And across these dimensions, we of course need to interact and respond in different ways. So looking at whole populations, we can promote using universal interventions to promote positive mental health, but then also target prevention of mental illness, and of course also then support and care people that are living with mental health conditions and for them to recover. So across this range, UNICEF is engaging. The Lancet Commission on Global Mental Health and Sustainable Development that released their report in October 2018, they made a range of recommendations that are not specific to children and adolescents' mental health, but are in fact global. And they stated that mental health should be reframed as a global public good and be a pillar central to universal health care and coverage. And that we need to use public policies to protect mental health. And of course, listen and engage with people with lived experience when we develop our interventions. We need to invest more and use research to guide innovations and the implementation. And of course, strengthen monitoring and accountability, which we will hear more about from Liliana. UNICEF is engaging across a very broad range of from promotion to providing mental health and psychosocial support. And that is also across the socioeconomic levels used in the socioeconomic model, from the individual to the family, community, and society. So I would say that UNICEF engagement is very broad going from the individual up to supporting systems, health systems, including health systems. We want to share some examples of UNICEF engagement in mental health and social well-being. And this is not a new area for UNICEF, and we want to acknowledge that I think the bulk of the engagement so far has been in the area of the emergency and humanitarian setting, with programs providing mental health and psychosocial support. But we are also engaging more and more in development settings, supporting health systems, as I mentioned, but also providing interventions in other platforms, including the education platform and in schools. Data and analytics, and Liliana's team will talk more about the measurement work that they are leading on. It is really important for us to really know what kind of interventions are needed in different countries, because now we are more or less engaging without the proper data at the country level, I would say. The Office of Research is leading on another line with, of course, research and looking broader at, for example, social protection programs and how they impact on people's mental health, and also advocacy. And I think we will hear more from that office before the end of the year. So please, Liliana, I give the word to you.
Thank you very much, Christina. So that was also a very helpful introduction. So now in the second part of the webinar, I'm going to describe the measurement process that we're going through, the methodological aspects of the work that we call MAP, which is measurement of mental health among adolescents at the population level. Oh, hold on. So before getting into that, just a couple of big numbers that are out there in the public domain. Some estimates are telling us that self-harm is indeed the second leading cause of death among adolescent girls ages 15 to 19. And for adolescent boys, the same age, is the third cause of death. So this chart here is confirming that. It's giving us the top 5 global causes of death among boys and girls 15 to 19. You see the boxes in purple being self-harm, and you see the other top 4 conditions that are causing death among adolescents. And as you see, self-harm is critically top in that list. And also the available estimates are telling us that 1 in 5 adolescents have a serious mental health problem or condition. However, what we know as well is that lack of data is an issue, because available data on mental disorders is representative of less than 7% of the young population. So those estimates that I just mentioned, the second and third cause of death being self-harm, 1 in 5 adolescents suffering mental health conditions, are based on just 7% of the population, more or less, right? There is very solid evidence that has been used to apply to models that have been extremely useful for advocacy. However, the lack of data coming from the population is a real concern. As you can see in the map, the countries in gray have no data on mental disorders or mental health conditions for young populations 5 to 17. And this is very recent evidence like this, this realization of the lack of data across countries. So this gave us a very solid reason and very solid ground to start figuring out as an organization what could we do to help in meeting that gap of evidence, that gap of data. And as you know, in the data research and policy in DNA, we have experience that dates like decades maybe, measuring issues among the population that are also of sensitive nature. So with this experience and with the support of a technical expert group from leading institutions and leading universities, we took the challenge to develop mental health among adolescents roadmap which final intent and purpose will be to develop a data collection tool for adolescents' mental health. Data to be collected at the population level that will tell us about the prevalence and burden of mental ill health that can be implemented in national surveys, any national survey, and that is also based on existing validated instruments. So we're not inventing anything from scratch. We're not reinventing the wheel. We're looking at the evidence. And so indeed, we started this work doing a review, almost a mapping of all the instruments to collect data among adolescents and mental health issues. However, this mapping help us realize even more, give us more evidence that most of the available tools have been developed to conduct data in clinical settings or in school settings, but there's not much in terms of population settings. So this also gave us the opportunity to look at the solid tools that were available already and start a process of adaptation, what is called cross-cultural adaptation, that will help us ensure comparability across different settings. The steps here are just for reference. I'm not going to walk you through that may get too long, but we're following some roadmap there with the support of the technical experts that will give us as a result this data collection tool that I had mentioned. I just mentioned about our experts. So we are advised by a technical group of experts coming from universities in various parts, universities in the US, Harvard University, or in Brazil, in Nigeria, Karolinska. We're working very closely with experts from Karolinska Institute, from George Washington University, that are leading us in this process. After the first technical meeting in March 2018, where we about 40 experts met in a room to discuss how to move this forward, we decided to narrow down the domains of mental health that we can measure to these 3 boxes that you see on the screen: depression, anxiety, and suicidality, with a level of functional impairment. As you know, mental health is in principle much broader than this. There are other type of disorders, learning disorders, eating disorders, or PTSD, phobias, other things, right, that are also very important. However, the advice from the experts was to just take these 3 big blocks in the assumption and understanding that there's very important comorbidities across these big domains. So by capturing information, good information in these 3 aspects, we're going to have a good sense of perhaps other aspects that are also part of the mental health concerns. In terms of the development of the tools, so having the 3-4 building blocks there, then we needed to identify what would be the appropriate instruments, how to measure that, what would be the right questions to ask. So we are looking at 4, we are following like 3 approaches. One, for depression and anxiety, we are looking at a validated tool that is called RCATS, Revised Child and Adolescent and Depression and Anxiety Scale. That tool has been used in more than 11 countries and it's been translated into very languages. However, it's a tool that is longer than what is desired for a national household survey. So we're in the process of, first of all, adapting it to local languages, and the Belize team is going to tell us a little bit about that. And we're looking into making it shorter so that it doesn't become a huge burden for household surveys. For suicidality, we're also looking at existing tools that have been used in school-based surveys. However, we're in the process of adapting it also for these settings, and also to have it to work in a cross-cultural setting as we need it. And for functional impairments, we're looking also at available tools and looking into adaptation as well. So this is what you see on the screen is sort of the skeleton of our process, of our methodological approach. So we're doing first adaptation and pre-testing on the left-hand side, and that's the work that we initiated in June in Belize. It is the bulk of the qualitative work in which we're bringing these tools that I just described to Belize. We're doing qualitative research with the youth in Belize. So we had the opportunity, with the support of the Ministry of Health and Belize Country Office to gather and meet with adolescents 10 to 14 and 15 to 19 for 2 days in a row, conducting focus group discussions that were extremely helpful, exciting, and wonderful experience. We also work with mental health in the country, and now we're proceeding to finalize this first phase with cognitive interviewing. Once that part is finished, and we estimate it to be finished within the next month or two, we will consider the tool to be adapted to this particular setting. With that tool adapted, we will move on to validation. And the validation process will have 2 main steps that you can see there. You see 3 steps, but I'm going to concentrate on just 2 parts to avoid making it too long. The first step will be administering the tool to a sample of about 300 adolescents and about 100 parents, with all the questions that have already been adapted. Once we have the results of that survey, we're going to call again the respondents and have a process that is called the validation process, basically, which is having these people being interviewed again, but this time by a clinician who has been trained to conduct a diagnostics tool that is done in a clinical setting. So first of all, just to recap, a person who answers this interview, the MMAP tool interview, then it's going to be called again to be part of a clinical assessment in terms of mental health. So this is a gold standard of validation in which results from a survey or from an assessment is validated against a clinical tool. We're going to do that with this small sample, and then once that is done, we're going to have enough information and enough very relevant data to evaluate the psychometric properties of the tool in terms of reliability and validity analysis, and conduct all this analysis, and then we will be able to tell that the tool is validated, it's good for the settings, it's solid. But all this process obviously this has to be carefully done in country. Once all of that is done, then we will look for an opportunity to include the module into a national scale survey in the pre-pilot process, because beyond how the element works by itself, then we need to see how it works with other modules in a survey. So we're going to look also for an opportunity to incorporate the module on a pre-pilot phase of a survey, and then have some final results. Beyond Belize, Belize is the pioneer for us. It's the best country, and we're very excited about this experience. We also need to look into other settings, because the idea to do the cross-cultural validation at the beginning is to be able to prove that the tool performs well in different settings. So we're looking into South Africa, perhaps Nigeria or Brazil, Vietnam, Mexico, and these countries have been identified through our technical advisory group, through experience with other experts in the countries, by knowing that some UNICEF country offices also have interest in promoting this part of the work. Once we do 2-3 processes, similar to what I have just described in other countries, then we would be able to liaise with University of Queensland, our colleagues there are conducting a process of measurement mental health in a much bigger sample, and we will include it as part of the pre-test pilot testing. So this is just part of the methodological work. And then with this, I can give the floor to Christina to tell us more about the HAT. And after Christina, we are going to hear from our colleagues in Belize, who can tell us more about the details of how the methodological work for the measurement went last month in June. Thank you. Christina, you have the floor.
Thank you, Liliana. So the Helping Adolescents Thrive, HAT as we call it, the project, is a collaboration between UNICEF and WHO. And the initiative is based on the increased demand for evidence-based interventions for adolescents. This includes the Lancet Commission on Adolescent Health and Wellbeing, the Global Strategy for Women's and Children and Adolescent Health, and the Global Accelerated Action for the Health of Adolescents, AHA. Guidelines will be accompanied by intervention packages and implementation guides, especially for low resource settings, for different delivery platforms, and targeting adolescents and specific vulnerable groups of adolescents, depending on context. The purpose of HAT is to promote adolescents' emotional well-being, their mental health and functioning, and to prevent mental disorders, risk behaviors, and self-harm. The HAT spans the universal and selective or targeted prevention segments of the IOM continuum of care model. So you can see it's about universal and selective prevention. Based on a systematic review and component analysis, a few program components emerge as mediating improvements across a range of mental health and other health domains. This review was done by the research teams that are based on in Stellenbosch University and Cape Town University in South Africa. The interventions, the components that were identified were interpersonal skills, emotional regulation, problem solving, and stress management. And the literature showed that there is a positive effect on positive mental health, prevention of depression and anxiety, and prevention of substance use. The review covered the period 2000 to 2018 and was based on 492 individual publications. The research team concluded that there is a good amount of data, but predominantly from high-income country settings. The development of the HAT intervention are based on a number of assumptions about the context where it should be implemented. The facilitators will not be mental health professionals, but rather teachers, counselors, low-level health professionals, or lay community members. There should be a firm public health foundation, but an intersectoral approach is also crucial. The diversity of cultural values, societal and capacity context brings the need for a simple, flexible core package that can be adapted before adoption and expanded with time. So the package will always need to be contextualized. A multi-level package with a universally delivered foundation intervention and then also targeted intervention content. And this foundation intervention could then be supplemented with additional modules for specific groups. And it should be group-based, interactive, and include a mix of skills and also take-home activities. And finally, any universal intervention always needs to be linked to healthcare services and referral. The package is being developed in consultation with adolescents, and the UNICEF Belize country office agreed to participate in this work. So we are very grateful for that. So in June, focus group discussions were held with Belizean adolescents to learn about their context, how they live, and how everyday life experience influence their psychosocial well-being and mental health. Focus group discussions are also planned in South Africa and Kazakhstan and will inform the finalization of the package. So who will use HAT tools? It's focused on different delivery platforms, as I said. So health, education, and social care providers can use it. Youth peer champions, policymakers, and health and social care planners, and program managers in the government and NGOs. The package is planned to be finalized by end of 2019 and will be tested in selected number of countries. Thank you. I will now hand over to the Belize country team.
Okay, thank you very much. So the team in Belize, first of all, would like to acknowledge the support that we received from the colleagues in LACRO, but also the colleagues in Program Division and the Division of Research and Policy who supported us in responding to this. But thank you too for the opportunity to share our experience. Our presentation is going to be in 4 parts. We'll talk first about the programming context in Belize and why UNICEF Belize is responding to mental health in adolescents. We'll then talk briefly about how we're supporting the response in Belize using the tools that Liliana and Christina have described. We'll highlight the lessons learned and then end with some recommended resources. So Belize is located in both the Caribbean and in Central America. It's the only English-speaking country in Central America. Its location makes it uniquely diverse ethnically, but it's also extremely diverse in terms of socioeconomic well-being and multiple indicators. It has a very young population. About 22% of our population here in Belize is adolescents, and over 40% are under the age of 20. This population size is estimated to grow significantly over the next few years. So meeting the needs of adolescents and young people is key for Belize's growth and sustainability. Economic productivity, competitive growth in Belize, but issues like security as well, and the optimization of this young human capital are really critical for growth and sustainability. And they depend very centrally on a healthy population that lives to its full potential and that enjoys full social inclusion and equitable access to quality, comprehensive basic services. So from that point of view, it's important to understand how mental health, which as Liliana described, can affect functionality and well-being for the individual, for their family, and for those around them, is so important for this young population and therefore an important cause for UNICEF to respond to. Since 2017, and building on the mandate given to us through the strategic plan to strengthen programming on adolescent health, UNICEF Belize, along with the government of Belize and other partners, including PAHO, UNFPA, civil society, and other government ministries, have supported the development of Belize's first national adolescent health strategy, using the guidance that Christina mentioned, the Global Accelerated Action for Health of Adolescents. Based on that guidance, we have supported the completion of a national adolescent health situation analysis. This data review exercise helped us to identify a range of adolescent health challenges. Secondly, we supported a nationwide consultative process, including district-level consultations, to review and validate those findings and to dig deeper and define unique priorities in each of the districts. What you see on this slide are findings from adolescents and service providers across Belize who confirmed that mental health is a priority for adolescent health. And this has informed us in including mental health as one of the major priorities within the National Strategic Plan. On the next slide, you will see just some pictures of the level and range of participation that we had in the course of coming to these priorities, and specifically the prioritization of mental health, with young people playing a key part, and over 233, for example, participating in the consultations at district level and national level. So the next slide shows some of the data on mental health in Belize. Liliana and Christina both spoke about the global perspective and the data available on mental health globally. We looked at data in Belize that, and this is what underpinned our decision to prioritize programming to respond to mental health in adolescents. The Belize Health Information System is a facility-based data system that records the services sought at service facilities. It's limited by underreporting because obviously not everyone who needs services actually presents to the facilities. But what that data does show is that attempted suicides, as you see on the left, have almost tripled in 15 to 19-year-olds in the period 2014 to 2017. On the right-hand side, you will see that 15 to 19-year-olds have the highest number of any age group in terms of number of attempted suicides. So it's very clear that in terms of measured health challenges affecting children in this age group, mental health is a significant cause for concern. At the same time, it is extremely poorly responded to, and we'll see that on the next slide. This slide shows the leading causes of mental health admissions at health facilities in adolescents in the age group 10 to 14 and age group 15 to 19. And you'll see that compared to the blue lines, which are the 10 to 14-year-olds, there's a sharp increase in mental health related admissions amongst adolescents aged 15 to 19 as a result of each one of these 5 leading causes. Those range from mood disorders through to the cause of the majority of the admissions, which is mental and behavioral disorders due to the use of psychoactive substances. So the challenges that we face in responding to mental health in adolescents in Belize include 4 main things: data, human resource capacity, the scale of program or availability of services, and also the coordination of services and support between sectors to ensure continuity of care. So with that, I'm going to turn to Jeffrey, who will describe what we've done through our program with support from colleagues from PD, from DRP, and LACRO to respond to this challenge. Jeffrey.
Thank you, Dr. Susan Cassidy, for making the introduction on why Belize is working on adolescent mental health. Now, my presentation will be focusing on how UNICEF is supporting response to adolescent mental health in Belize. And this slide is showing a strategic framework for the Belize Adolescent Health National Strategic Plan 2019 to 2030, including shared vision, mission, expected 3 outcomes, and it also includes the 15 provisions for improving adolescent health, and which are agreed by the government and implementing partners. Highlighted in yellow, these strategies are leveraging partnerships, quality services, power of data, and advocacy and social mobilization. So for my presentation on UNICEF program support to adolescent mental health in Belize will be aligned to each relevant strategy. I will start with the first one, which is quality services for at-scale results for, for adolescents. Sorry, the slides. Let me move the slides. Sorry, I have a little technical problem here. Okay, now it's moving. So, okay, so I will start with the first one, quality services for at-scale results for adolescents. And together with government and UN partner agencies, UNICEF Belize facilitated with drafting adolescent health norms and standards, which includes a description of a minimum package of services for adolescents and the guidelines on modalities and schedule for delivery. It aims to strengthen early detection, screening, and referral at the community or primary healthcare level. The 10 service packages define the required level of quality in the delivery of services for adolescents in Belize, including mental health. So on the left-hand side of the slide, Belize launched the U-Report mobile platform last year. A recent U-Report poll was created to collect basic data on mental health in adolescents in Belize, to ensure broader adolescent engagement and the participation in the mental health programming. And the picture on the right-hand side is showing to further build on this new technology innovation in collaboration with Ministry of Health. Mental health counseling will be gradually made available countrywide through the unique U-Partners function, which enables delivery of scheduled, confidential, and quality assured one-on-one counseling through trained operators via mobile phone. The U partner is not to provide specialized authorized professional mental health counseling services. It aims to offer basic information. It also offers an opportunity for earlier facilitated referral to a health facility. Now I will come to the second strategy, leveraging partnerships for adolescents. And last year, UNICEF Belize extended our results-based management training to include government and implementing partner agencies. We had a working session with Ministry of Health, Ministry of Education, Belize Family Life Association, which is an NGO in Belize, to develop a theory of change for adolescent mental health. And also last year, the mapping exercise was conducted last year using the UNICEF and WHO tool for W2, who is where, when, and doing what. The exercise is to map out organizations providing mental health services to adolescents aged 10 to 19. And the mapping exercise will help to give us a better picture of who are providing services to further build partnerships on addressing adolescent mental health issues. Now, the third strategy is using the power of data. So as Liliana mentioned in her slides, our MAP project is to measure prevalence and the burden of mental health among adolescents 10 to 19 at the population level. And in my presentation, I will be focusing on how it's operationalized at the, on the ground in Belize. So supported by UNICEF and George Washington University, Ministry of Health recruited local language experts, local mental health experts, school counselors as facilitators to move ahead the MMAP project in Belize. And 2 local language experts translated the MMAP tool into the language that the tool is comprehensible to adolescents. Here in Belize, majority of the Belizeans are English speaking. However, most people speak Belizean Creole, which is an English-based local language at home. The tool was translated into Belizean Creole as well. And 3 local mental health experts adapted the translated tool into the Belizean context to reflect local interpretation of the survey items. And before we had a focus group discussion with adolescents, we had a training of local facilitators with a technical assistant from UNICEF HQ and George Washington University. And 100% of the research group and facilitators passed the ethics testing. And for the focus group discussion with adolescents, it ensured valuable inputs collected from adolescents to further make the tool in a way that Belizean adolescents could understand. The samples of older adolescents aged 15 to 19 were recruited by Department of Youth Services. The samples include in and out of school adolescents, adolescents from crime hotspots, gender balance, and we include those with English as a second language. Because here in Belize, we have a large 50% of the population are Spanish speaking. And the younger adolescents aged 10 to 14 are convened through Ministry of Education, and they are mostly students from primary and secondary schools. The focus group discussions have been carefully structured to be suitable for younger adolescents aged 10 to 14, as well as older adolescents aged 15 to 19 from different backgrounds. And the adolescent participants demonstrated a high level of interest and provided invaluable inputs and insights, which will assist greatly in finalizing the tool. And here are the pictures showing the focus group discussion with the 6 parents recruited in Belize. They are the parents of adolescents aged 10 to 14. And finally, we will the next step would be the cognitive interview with adolescents to make sure the questions were complete and the tool is ready for the data collection, which is the the phase 2. And UNICEF Belize also introduced Helping Adolescents Thrive project. As Christina mentioned in her presentation, it is a multi-country initiative to support the development of the guideline on mental health promotion and the preventive interventions for adolescents. In Belize, the project involves 5 steps. First, Ministry of Health and the Ministry of Education had a meeting with UNICEF to review and provide comments to the draft HAT protocol and adapted it into the local context, which is step 1. And for the step 2, just last month, with support from UNICEF and Stellenbosch University in South Africa, Ministry of Health arranged a workshop and the training of local facilitators on the concept and strategies to be used for the qualitative research through focus group discussion with adolescents. And adolescents were recruited through the same channel as MMAP, which ensured in and out of school adolescents, there is a gender balance, etc. And data are now being transcribed and will be then analyzed and utilized to make adjustments to both for the HAT project and also for the MMAP project. So a total of 52 adolescents were recruited for both HAT and MMAP projects. And the last strategy is advocacy and social mobilization for adolescent mental health. And last year, we were excited to have communication for development training. And we had the adolescent health cluster led a C4D strategy on adolescent mental health. Now the strategy is being drafted through the adolescent health cluster at the C4D, and the draft will feed into and the data we collected will be fed into the C4D strategy. And on the right-hand side of the slide, it's showing our Child Advisory Board, CAB members of Dangriga district. The adolescents participated in a training on communications and working with the media. And through our Sustainable Child-Friendly Municipality initiative. And as you can see in the picture, adolescents have concern about the violence that are affecting them. The violence, the high homicide rate, and the high crime rate in Belize actually are contributing to the poor mental health for the adolescents in Belize. And this slide is showing how we use the broad media coverage to make adolescent mental health issue more visible and give the public a better understanding of how UNICEF is tackling this area of importance. UNICEF, also on the right, we held two town hall meetings. And the most recent one, we were very excited to have our special envoy, the First Lady of Belize, to be our keynote speaker. And she called for greater investment in mental health, highlighting the fact that only 2% of the Belize health budget covers mental health, and she's calling greater investment in adolescent mental health. So these are the 4 main lessons learned from Belize. First, the health itself depends on many factors reaching far beyond the health sector. Improving health requires a strong multi-sectoral collaboration with other sectors. And the second, Ministry of Health is leading the projects. This led to many results. First, the development process was moving forward smoothly because it was led and owned by the Ministry of Health. Second, the formal outreach by the Ministry of Health to other ministries and other stakeholders ensured multi-sectoral nature of the extended working group, and the efforts on system strengthening are both multi-discipline and multi-stakeholder. The third one is the effective adolescent participation in the entire process of adolescent programs. So adolescent programs are included in our research group, and they are engaged in every step of design and implementation process. and trained by UNICEF, and one of the youth facilitators actually facilitated the HAT focus group discussions. And the use of U-Report ensured broader adolescent participation, and at last, a qualitative component included in the testing of the MMAP data collection tool ensured valuable inputs from adolescents, and the tool was adapted based on their inputs. And at last, using the power of data to drive change. So first, adolescent health situational analysis reviewed the existing facility-based data, and they are disaggregated into age group of 10 to 14 and 15 to 19. And the data disaggregation helped to show the hidden epidemic in adolescents. However, when no facility-based data are collected where the services are provided and available, that's why we are very excited to have this MMAP project to help us measure the burden at the population level. Once it's completed, it will promise to offer Belize a new and extremely valuable perspective on mental health, and the insight that the government truly hopes and will help transform the way that we speak, measure, and respond, and plan for mental health from individual to policy level for greater investment. And here are the recommended resources, including newsletter and a webinar that we had on the National Strategic Plan Development, reports, some global guidance, and each of the resource has a hyperlink and the media coverage. That's it. Thank you.
Thank you very much, Jeffrey, Susan, Christina, and all the colleagues who have contributed so greatly to this webinar. We have less than 10 minutes, sorry, for some key questions. And so we open the floor for questions from the participants. It can be written in the chat or just unmute yourself and feel free to ask any questions. It sounds that there are not many questions. So just to say, as Jennifer mentioned, this webinar was recorded, so it will be made available in the website, at a minimum in the data.unicef.org website, and also possibly in the Belize website, also the presentation. I see 2 comments coming up in the chat. Let me see. Let me read it out loud. Wondering if the sharp spike in data is because there was no data before. In other words, the sharp increase in data, I'm assuming this is Sarah, I think, Sarah Crow. Yeah, thank you. The Belize data on attempted suicides. So that's a question for colleagues in Belize.
Yes. Yeah, so the Belize Health Information System has been collecting data on various conditions for a while now. And so we do not, it's not the case that there was no data before, but the Ministry of Health has noticed that sharp spike. Well, not spike, but the growth in the number of attempted suicides since 2014, as was shown earlier on that slide. It's been increasing steadily from 2014, and the work that we're doing on mental health will help to highlight or shed further light into what has changed to contribute to that rising number of attempted suicides. At the moment, based on the discussions to date, there is concern around the increased accessibility, for example, of alcohol and drugs, but also the effect of rising levels of violence and or sustained levels of high crime in particular locations. But there is also the advent of technology and increased use of technology, which has contributed in some ways to exclusion, but also to addition to stress experienced by this particular age group and younger, 10 to 14-year-olds. So there are a number of indications as to what the cause may be, but the data certainly was and has been collected over a period of time, but it's clear it is rising.
Thank you, Susan. We still have about 5 more minutes for questions. So I see one from Angus. For Susan, I'll read it aloud. Hi, Susan, let us touch base on possible participation of Belize at the Mental Health Conference. This is from Priscilla. We get excellent presentations. Congratulations to all. And from Fernando in Argentina, thanks for the presentation. We want to be in the loop. You are gathering and building very useful evidence. Thanks everybody for the encouraging words and interest.
Hi, can I jump in?
Yes, please.
With a question? Hi, everyone. This is Crystal from the Disability Section in Program Division, the UNICEF headquarters. Yeah, thank you for this presentation. I was just wondering if you had any reflections around adolescents' right to seek help based on free and informed consent from the adolescents themselves, because we know there's a lot of adolescents that are treated, that receive medication, that are placed in psychiatric institutions without their consent. And on the other end, we have parents who deny their kids from getting help because of the stigma attached to mental health crisis. So just wondering if you had any reflections around adolescents' free and informed consent to mental health care. Thanks.
That's a very relevant question, Krista. Thank you much for asking it. From the perspective of what we're doing at the moment, we're making sure to have all the consent processes and having adolescents understanding what they are getting into. This is not answering to your question specifically, and I see that the issue that you are putting on the table is much broader than what I'm addressing. But just to say, in the scope of work that we are doing for program and for measurement, we're making sure to check all of the ethical requirements in terms of assents and consents, and they understanding and knowing that this is not about treatment or putting them in institutions or anything like that, but it's about them sharing their experiences and feelings in terms of mental health, which is also a very sensitive area. Beyond that, I don't know if Christina or colleagues in Belize have any reflections on that.
Sure. From the national workshop that we had on mental health to kick off the work on MMAP and HAT, the First Lady spoke very, very pointedly in the opening about stigma and the effect that this has on families. One of the effects being that families tend to hold back, and not disclose or not facilitate full access to support and care. We also had a personal testimony from a young person who had been through multiple experiences to try and secure support necessary and had not been able to benefit from the best possible support necessary to diagnose and ensure the right care. So we know that there are significant gaps in care. We know that stigma plays a strong part. And we hope that in responding to this, as Jeffrey highlighted, we're going to be able to address that not only by providing indications from this work that's being supported through HAT and MAP to improve quality so that we can build confidence, community confidence in the services and literacy around mental health. But we also want to make sure that we address stigma directly through the communication and advocacy, because demand for the services and support for access to services, consensual participation in the care available will only be improved if we really are able to support ensure that there's support in the community and family for that care. So we're mindful of the challenges with respect to access, consent, and stigma are part of that challenge.
Thank you very much.
This is Christina. I just wanted to share an experience from working with colleagues in Kazakhstan, and they started in one region, but have now, the government have now extended the program nationwide. But this has, of course, not been an easy task, and there are many, I would say, forces and individuals, but also groups in society that really wants to put the lid on the issue of mental health, and also arguing that by talking about it, you raise risk instead of reducing risk. And I think the issue of stigma and discrimination is something that we always need to consider in our programming, and also have strategies to actually interact and react to these possible negative feedback that comes, and it's about learning and informing. So I think the issue of the awareness raising and combating stigma and discrimination is something really important as a basis for anything we do in the area of mental health, especially for children and adolescents, because there can be very negative consequences if people start to say that it's harmful rather than the other way around. So I just wanted to add that. It's not a response to Christel's question, but a comment. Over.
Thank you, Christina. So it's 3 minutes past the hour. So I want to thank you all the participants for their questions and for their attention, and mostly for their interest in this important topic. The presentation and the webinar will be available online. And so feel free to reach out to any of us for additional information. Thanks, everybody. Have a good rest of the day.
Thank you. Bye-bye.
Bye.